I'd like to introduce our first speaker. This is Keith Strauss, who was also here at the Dose Summit. How many were here for the Dose Summit before this meeting? All right, so we got a good crowd there. And that's why we wanted Keith to take one of the topics that was discussed during the Dose Summit and add some additional information to it. Keith is going to be talking about size-specific dose estimate, and he is eminently well qualified to talk about this because he was one of the co-chairs. He was the co-chair of TG 204, who did a lot of work about this. Keith is at Children's Hospital in Cincinnati and has been on multiple AAPM task groups related to CT dose. So I'd like to welcome Keith. Thank you very much.
Well, good afternoon. I assume people in the back row can hear me? All right. So my task today is to talk about SSDE, or the size-specific dose estimate. Some of you may be asking the question that's here in the title, why do we need another CT dose index? And that's what I'm going to try and answer this afternoon. I'd like to acknowledge my co-conspirators that helped develop the size-specific dose estimate concept through TG 204, through the AAPM. And I'd also like to thank Don Fry and Tony Seibert for some slides that they loaned me that I've adapted for this presentation. So I want to say a few words about Imagenologia. I'm a pediatric guy, for those of you that don't know me, and this discussion this afternoon is going to be heavily oriented towards pediatrics. It's really oriented towards patients of multiple sizes, and so it's just as applicable for bariatric patients as it is pediatric patients, but I'll tend to talk more about the pediatric patients. What are pediatric CT public health concerns? I want to talk a little bit about the effect of patient size on dose indices. I want to talk about the shortcomings of the standard dose indices that we've had for a number of years, which creates a clinical dilemma, and essentially that's why TG 204 was created. And then I really want to spend the bulk of our time talking about managing pediatric CT patient doses and applications of SSDE in the clinic. All right, so the Image Gently campaign, officially the name of the organization is the Alliance for Radiation Safety in Pediatric Imaging, and it was created back in 2008 to try and increase the awareness of the need to better manage radiation doses, especially to small children. Today, that represents about 75 healthcare organizations and agencies throughout the world, and we believe that it represents about 800,000 individuals that are working in the medical arena. Imagenologia believes in a positive message. You'll never see a message like this in red from Imagenologia, and for that reason I'm not even going to read it. I'm going to make you read it, but it's a negative statement, and that's not the purpose of Imagenologia. Imagenologia is interested in increasing awareness through education, advocacy, and we're really interested in trying to change clinical practice. The problem is that typically it takes 17 years, even in today's world, for a new idea that's written about and published to find its way into daily use in the clinic. And we want to shorten that time period. The founding organizations of Imagenologia were the Society of Pediatric Radiology and the American College of Radiology, of course representing the physicians, the American Society of Radiologic Technologists representing the technologists, and of course the American Association of Physicists in Medicine. What are the health concerns of kids relative to adults? This is a slide that was put together by Eric Hall a number of years ago, and I think it kind of summarizes the increased concern with children. And basically what we have here is we're making the assumption that we're delivering a dose of a whole body dose of 1 sievert to a group of individuals, and we see in this graph that on average The attributable lifetime risk of cancer as a result of one sievert of dose is approximately 5% for males and almost 6% for females on average. In the first decade of life, it's approximately 13 and 15% for small children. Once you get to being middle-aged, it falls down to about 2 or 3%, and I must admit it's one of the few things I found about middle age that is positive. But at any rate, from this we can assume that children are about 3 to 5 times more sensitive than adults. Another point I want to make that sometimes is forgotten by those that don't work a lot with pediatrics is that there's a huge difference in patient size. You all are aware, working in adult institutions, that the largest bariatric patients can have dimensions as great as 45 centimeters, and I'm talking about essentially the path length of the x-rays through the patient's body. The newborn or the neonate's going to be about 6 centimeters in size. Okay, so we have about 39 centimeters difference, and you say, okay, so what? Well, what's the half-value layer in CT in tissue? Well, at 70 keV, which is approximately what the energy of the CT beam is, we've got a half-value layer of about 4 centimeters. That means we've got about 10 half-value layers difference between the smallest patient and the largest patient, which means that I need a minimum of 1,000 more x-rays to penetrate the largest patient versus what I need to penetrate the smallest patient, everything else being equal. That gives me a great opportunity. That gives you a great opportunity. All of a sudden, we've got x-rays to burn. We've got x-rays to waste when we're imaging the smallest patients. And that gives us an opportunity to do a lot of things that are more creative than what we can do with adults. All right, so let's look a little bit at some of these standard CT dose indices and kind of review what they mean. In the real world, when we irradiate a patient with a CT scanner, we get a dose distribution as shown here along the z-axis of the patient. We have tails due to scatter, and we have round off of the peak dose, also due to scatter. This dose distribution is characterized by the full width at half maxima, and that full width at half maxima is equal to n times t, where n is the number of detector elements in the z direction, and capital T is the dimension in the z direction of each one of those elements. When Mike McNick-Gray talked yesterday about this at the Dose Summit, he called it nominal collimation, and essentially that's what it is. It's the fan beam width, if you will, coming from the CT scanner. Obviously, you're physicists, you know that an integral just means that we're measuring the area under this dose distribution when we measure or calculate the CTDI. So let's go through a little experiment. Let's measure some actual CTDI vols. And when I did this, I used the same KV, the same tube current, the same rotation time. I used the same bow tie filter. That's highlighted in color here because you normally wouldn't do that clinically, depending upon the scanner. As you go from a small patient to a large patient, a lot of manufacturers elect to change the bow tie filter's shape and thickness, and that's going to change the output of the beam and the amount of radiation reaching the patient. So I selected 3 phantoms. I made the measurements. These are the results I got. I can calculate the CTDI vol. I get 47 milligray for the smallest patient. I get 18 milligray for the largest patient. And you note that for the largest patient, the dose is 2.6 times smaller, 18, than it is for the smallest patient. That's significant in the fact that, what do we know? The scan parameters were identical. So what does that tell us? That tells us that the radiation production of the scanner was identical for all 3 of these measurements. And while I delivered the same photon flux in each case, my dose to my phantoms in this case is different by almost a factor of 3. So that's the measured CTDI vol. How does that compare to the displayed CTDI vol that you see on the scanner? Well, the displayed CTDI vol represents the distribution of dose given to one of the two CTDI phantoms, which are either 16 or 32 centimeters in size. It's a powerful tool. It reflects changes in the voltage across the X-ray tube, the tube current, the rotation time, the pitch, again, that bow tie filter, and the source to detector distance. And again, I'll highlight the source to detector distance because a lot of people tend to forget that different manufacturers use different source to detector distances, and because of inverse square law, the radiation output, even if everything else is going to be equal between two vendors, which it's not, but assuming it was, the output at the detector is going to be significantly different, and for that reason it doesn't make any sense to talk about comparison techniques or comparison doses to patients by comparing the MAS. It drives me crazy working with my pediatric radiologists because they like to focus in on the MAS, because somewhere they got the concept that that tells us the patient dose. And they'll take a CT scanner that's got short geometry versus a scanner in the same department that has long geometry, and they think that if the MAS of the two scanners is the same, then the patient dose is going to be the same, and that's actually not the case. So CTDI vol is just a standardized method to estimate the radiation output of two different scanners to the same phantom. It does a beautiful job of doing that. That's what it was defined to do, and that's all it was intended to do when Tom Shope and others at the FDA defined CTDI a number of years ago. All right, so here's our first SAMS question. CTDI vol is measured with a point ionization chamber such as a Farmer chamber. Displayed by the CT scanner represents the radiation dose delivered to the patient. Is a standardized method to estimate and compare the radiation output of two different CT scanners to the same phantom, or can be measured with a single measurement in the correct CTDI phantom. All right, so the timer started. You've got 10 seconds to jump on your clickers. Okay, so we had somebody that was distracted a little bit by the last choice. Okay, we can't measure CTDI vol with a single measurement. We've got to have two measurements, because we have to calculate the weighted CTDI, and to do that we need a surface measurement and a centralized measurement before we can calculate and come up with the CTDI vol. So obviously we're using a pencil ionization chamber, so one is wrong. The CT scanner represents the radiation dose to the phantom, not to the patient. And as we've already said, we need more than one measurement. Okay, so let's go back to my experiment. There's my measured CTDI vol. Now, how does that compare to the displayed CTDI vol? Well, if the scanner chooses to use the 16 centimeter phantom, it's going to display 38 or 37 milligray for each of the three cases. If it chooses to use the 32 centimeter phantom, it's going to display 18 milligray. So what do you note? You note that the CTDI vol that's displayed by the scanner contains what? Zero information about patient size. It tells us all about how much radiation was delivered to the patient, but it tells us nothing about the patient dose as a function of its size. So the displayed CTDI vol is independent of patient size, because it's defined to a phantom. If I use the 16 centimeter phantom, my adult dose will be overestimated, while if I use the 32 centimeter phantom, my pediatric dose will be underestimated. And if it's a newborn, it's going to be underestimated by a factor of 2.5. Not 20% or 30%, but 2.5 times. And of course, because we're taking the CTDI vol and the DLP and putting them in the patient's medical record, we're propagating that error. So the dilemma is that CTDI vol doesn't represent patient dose. Well, what do we know about pediatric doses in CT? Well, this is a table, or actually a little worksheet that was put on the Image Gently website back in 2008. And what it was designed to do was allow someone to come up with techniques that are appropriate for children. And what you do is you fill in the KV, the tube current, the time, the pitch for both the abdomen and the thorax that you would use for your adult patient in your department. And you put that MAS value in here where it says fill in. And once you do that, the table populates and it gives you the reduced MAS that you need as a function of patient size to do what? This table was designed to keep the patient dose equal as a function of size. And so this table was not designed to reduce pediatric doses relative to adults. It was designed to keep the dose the same. You say, well, why? Well, don't forget that what would have happened had we not adjusted the technique? What would the pediatric dose be? For the newborn, it would be 2.5 times greater. So in this case, you're reducing the dose to the youngest patients by a factor of 2.5. So in the second half of this lecture, I'm going to talk about the fact that we can do a lot better than that today and how you can use that information to help sites set up pediatric protocols. The ACR has standards that they've published. You're familiar with them, I'm sure. They're less than 25 milligray for the body, less than 75 milligray for the adult head. The pediatric body is less than 20 milligray. That value is going to change in the not-too-distant future. And in the not-too-distant future, we're going to have a reference value for the pediatric head. And I'll let that go until the next lecture for that to be revealed. I'll give you a reason to stick around. So the pediatric patient dose should be less than or equal to the adult dose, and again, it would be 2.6 times greater if we did nothing. All right, so as a result of that dilemma, the AAPM put together the task group. We developed this report. You notice that the title says that it's for pediatric and adult body CT examinations. It means it's also good for bariatric patients. Notice that it applies to all body exams, so thorax, abdomen, and pelvis. The report's not a be-end and end-all. It doesn't address correction factors for heads. They weren't developed. Doesn't address the small difference or the small doses generated by the scan projection. That should be less than 1% of the actual dose to the patient. Doesn't correct for the approximately 5% error between thorax and abdomen. In some respects, you might think that the error would be greater because obviously lung tissue has a lot of air in it instead of soft tissue. And it doesn't correct for the small variations in pre- and post-contrast scans. It also doesn't address the lost tails that we miss with our 100-centimeter pencil chamber. And I'm assuming that as physicists you're aware of that, and that that's what was actually addressed in TG 111, and that's beyond the scope of this presentation. And TG 204 had no intention of addressing that. So what's left? What is it? Well, it's an estimate of the average patient dose within the entire scan volume of the patient. It adjusts for size and varying attenuation within the patient. Now, if you think about it, the amount of radiation that's being delivered to the patient is dramatically varying at all times during the scan if you're using automatic exposure control features of state-of-the-art CT scanners. The output varies along the z-axis. The output varies as the X-ray tube rotates about the patient. And the output's also going to vary based upon what bow tie filter is selected based upon the scan field of view of the patient. All right, next Sam's question. SSDE, size-specific dose estimate. Calculations account for the differences in pre- and post-contrast scans. Conversion factors for the head are smaller than those for the trunk. Calculations include corrections for the dose of the projection scan. Reference values published by the ACR are less than 20 milligray for a pediatric 5-year-old body. And 5 does not correct for the failure to capture complete scatter tails when using short phantoms as addressed in AAPM task group 111. So the timer started. Man or woman your clickers. Okay. All right, so 83% of you are awake. 17% were distracted a little bit by item number 4. The point is, it's a subtle point. The reference values published by the ACR are based upon CTDI vol. They're not based upon SSDE. They're based upon CTDI vol, and it's important to keep that in mind. Okay, so I won't belabor 1, 2, and 3. You guys all have that down pat at this point. So how was TG204, how was it developed? What did the authors do? Well, there were 4 groups across the country collecting data with respect to dose in CT. Cynthia McCullough's group was working with anthropomorphic phantoms. Tom Toth and I were working with all the major CT manufacturers, and we're limiting ourselves to the 2 CTDI phantoms and the 10 centimeter cylindrical phantom of similar design. Mike McNick-Gray in his laboratory was doing Monte Carlo computer modeling, and likewise so was John Boone in his laboratory. And so we took all our data, we combined it, and we were shocked when we did a fit that we got an R-squared correlation factor of 0.94. What we have here is the effective diameter of the patient and what's called a normalized dose coefficient, which is just going to become our conversion factor. And this data is for the 32 centimeter phantom at 120 kV. We notice that our conversion factor for our smallest patients are about a factor of 2.6. Do you remember that number? Because that 10 centimeter phantom I used in my experiment is about the size of the smallest pediatric abdomen, roughly. We get to the largest bariatric patients, and our conversion factor is actually less than 1. We can do the same thing for the 16 centimeter phantom. Now, obviously, our conversion factor is not as great for our smallest children and is considerably less than 1 for our largest patients. Again, this is at 120 kV. Correlation factor, again, of 0.967. So you say, well, that's great, Keith, but we do CT scans at 80 kV, 100 kV, 140 kV. What about that? Well, here's that original curve at 100 with 120 kV data only, and here's the like curve for 80, 100, and 140 kV data. And you see here that at this point we have about a 5% error. Once we get to 15 centimeters, which corresponds to a 1-year-old, we have about a 3% difference, and greater than that, the percent difference is even smaller. So basically we can say that the conversion factors generated by TG204 are good for any kV. What's the effective diameter that was plotted on the abscissa? Well, it's just simply equal to a circle with an area equal to the area of the patient's cross-sectional axial image. If we know the AP and the lateral dimensions, we can calculate the effective diameter of the circle. Well, how do we figure out what the patient's size is? Well, one of the things that you might be tempted to do is say, well, let's just use the patient's age. We know the patient's age. Well, this is a plot of patient size of the AP abdomen that was published in 2010 of 336 patients, from newborns all the way up to 20-year-olds. And what I can do is I can draw a straight line here, which of course represents patients all of one size. And you see here that my smallest 18-year-olds are exactly the same size in girth as the largest 3-year-old. Of course, my point here is that age is not a good indicator of patient size. And so that's discouraged, and we are encouraging everybody to actually measure the size of the patient. You can do that by measuring the lateral dimension with mechanical calipers. On the projection scan, you can measure electronically the AP or the lateral dimension of the patient, depending upon which projection scan you took. Obviously, if you take the AP or PA projection scan, you're going to be making a lateral measurement. As a word of caution, make sure that the patient is centered in the gantry when you do this on a projection scan so that you don't have magnification error. Importantly, you can use the projection error, image, which allows you to do what? It allows you to calculate the SSDE when? Before or after you actually do the scanning? Before you do the scanning. And so as a result of that, you can get the patient's size, calculate the SSDE, and compare it to a reference SSDE in the department to determine whether or not you need to modify your parameters before you give the patient the 99% share of the dose that they're going to get from the exam. So that's an important point. If you've already made the scan, you can get both the AP and the lateral dimension off the axial reconstructed image. Now, as a word of caution, you have to know which phantom the CT scanner used to display the CTDI vol. The bad news is that there's no standard that exists. Abdomens may be represented with the 32 centimeter phantom for all patients. Some manufacturers use the 16 centimeter phantom for small patients. Some manufacturers use the 32 centimeter phantom for large patients. There is a mix, so what we recommend that you do is make no assumptions. Find out what your scanner is actually doing through the service organization of the manufacturer, because in some cases my understanding is that for a given model and manufacturer there might even be a difference in this depending upon what year the scanner was manufactured, or it also may be dependent upon the software level. This is just one of a couple tables that appears in TG 204. It gives you the effective diameter and the lateral plus the AP dimension, or the lateral only or the AP only. And here's your correction factors. I got a question yesterday from somebody. They said, well, gee, I don't really want to look this up in tables. Are there coefficients anywhere? There are coefficients in the appendix in the back of the publication, so that if you want to build an Excel spreadsheet that will automate the calculation of SSDEs based upon the fitted curves, you can do that. We believe the accuracy is about 20%, which should constantly remind us that this is nothing more than an estimate of patient dose. It's not the actual estimate of dose, or it's not the actual dose, it's an estimate. And as a result of that, we shouldn't calculate SSDE and quote it as 2.7539 milligray. If we have more than 5 milligray, we're recommending just integers. Less than 5 milligray, we're recommending 1 decimal point. So how does the calculation work? Let's assume that here's my projection scan. My dimension is 16.8 centimeters. The CT scanner used the 16 centimeter phantom. The displayed CTDI vol was 9.3 milligray. Here's the correct table because this was a lateral dimension. I come over here and I select 17, and I have a correction factor of 1.06, or 1.08, I'm sorry, and I come up with an SSDE of 10 milligray. There is some boilerplate included in the report that is there for radiologists if they live in a wonderful state like California where they're forced to put dose information in the patient medical record. Today they're required to put in CT-di-vol and DLP, which we've already talked about, problems associated with that. I won't read this, but I think if you read this and think about it, if the radiologist were to use this boilerplate language, 20 years from now, somebody could look at that dictated report and know exactly what dose was reported and what it means, and of course that's important. Okay, next Sam's question. SSDE as a calculation has an estimated error of 10%, accounts for both the radiation output of the scanner and the patient's size, cannot be estimated until after the CT examination of the patient is completed, is more accurate if the patient's size is estimated based on the patient's age, and should not be used for CT examinations of the thorax. Timer's begun. All right, how'd we do? All right. You guys obviously understand that it's accounting for both the size and the radiation production by the scanner. If we use the projection scan, we can do an SSDE calculation prior to completing the exam. Okay. Prior to SSDE, what was the trend if somebody wanted to talk about an individual patient dose? What did people do? They calculated effective dose. Okay? Well, how did they do that? They took CT-di-vol, they looked up the right K factor, they took the product, and voila, they've got an effective dose. A lot of people did that. That's been published in a lot of places. What people tend to forget is that that's an inappropriate use of effective dose. Effective dose was originally defined to address radiation protection concerns of the occupationally exposed workers. It's not defined for patients. Now, it is true that I can use effective dose appropriately to compare biological effects between two diagnostic exams of different types, but please notice, there's nothing in this that suggests that we're doing this for individual patients. If I were doing H here, I'd be doing it for large groups of patients. I'm comparing two different exams. So effective dose is not a patient dose. It's not to be used for an individual. It's not technically defined for children. And it was never meant to just estimate cancer risk. It assesses more than just this risk. And if some of this is new information to you or contrary to what your understanding was, here's a very effective reading list that you might want to look up. This will be in your handout or what's published in the virtual library, so you can dig into some of this information. Okay, next Sam's question. Effective dose can be used to compare biological effects, diagnostic exams of different types. Has an accuracy that's improved when the SSD is multiplied times the appropriate K factor instead of CT-di-vol. Can be used to estimate an individual patient's radiation dose. Can be used to estimate organ doses. Was originally defined to address radiation protection concerns of medically exposed patients. Grab that clicker. All right, how'd we do? Okay. Effective dose was originally defined to address radiation protection concerns of occupational workers only, not medical patients. So the number 5 is a distractor. The correct answer, which the majority of you got, was number one. It can be used to compare biological effects of diagnostic exams. Okay. So, that's the foundation. Now, what can we do with SSDE that really makes a difference in the clinic? Well, if you went to the dose summit, you would have heard over and over that ideally unique scan parameters should be established for each individual patient, accounting for the patient's size, the CT examination type, and the design of the actual CT scanner. This can be done in academic centers with diligent effort. I have no quarrel with this approach. The problem I have with this approach is, what are the odds that this will happen for the occasional pediatric CT scan completed in a good community hospital? I would be brash enough to assume slim and none. Okay? Yet the majority of pediatric CT imaging in the U.S. does not occur in dedicated pediatric hospitals. There are 37 dedicated pediatric hospitals in this country. We don't have the actual numbers, but we believe that there is no way that more than 20% of all pediatric imaging done in this country is done in a dedicated pediatric hospital. That means that 80% of all children pediatric studies using ionizing radiation are done in adult hospitals that, if they were brutally honest, they would probably admit that, we'd really rather not do these patients. But we're the only game in town, and we need to do them. So the question for you and for me and for all of us that are consulting medical physicists, how do we deal with this? Because it's you that needs to go into your facilities that are primarily adult hospitals and help them set up pediatric protocols. So I'm going to give you a solution. It's not the only solution, but I'm going to give you a regimen that you can use as a consulting physicist that I would claim it takes a reasonable amount of effort. The first thing you do is you review the CTDI vol measurements completed by the facility's medical physicist, which is probably you. Okay? So it shouldn't take too much review. Okay? And you should have some confidence in those results, I hope. Okay? So you've got your CTDI vol measurements. Okay? And the site CTDI vol should be less than the ACR reference values. Now remember, the ACR reference values are expressed in CTDI vol. You can make a direct comparison. So, if the ACR says that for an adult head, you should be less than 75 milligray, and you've made measurements in a particular facility and you identify that the clinical dose for heads in that facility are 60 milligray, they're probably doing a pretty good job. All right? So I want you to do this comparison to make sure that the radiologists are doing a reasonable job and their image quality demands are not unreasonable. And I'm making the assumption that if they're meeting the guidelines of the ACR, that they're not. Okay. Now that you've done that, you can calculate the SSDE after the scan projection image of a pediatric patient is complete. Remember, you have not yet primarily irradiated the patient. You've given them 1% or less of the total dose that scan is going to create. So you measure the patient width. You know the size of the CTDI phantom that the imager used to display the CTDI vol. You know the CTDI vol. You've got your trusty copy of TG204. And you can calculate the SSDE. And you can compare it to a reference SSDE in the department. And then, hopefully, the technologists, the radiologists, and you can huddle up and figure out what the best approach is to adjust the scan parameters if what? The calculated SSDE is greater than the reference SSDE. All right? Now, remember, I'm not talking about hundreds of patients in the adult institution. I understand that adult institutions are like factories and they got to crank the patients out, and I'm not used to that in a pediatric institution. But if an adult facility is doing 3 or 4 pediatric patients a week, things can slow down for that pediatric patient. There's probably a lot more issues with that pediatric patient than the amount of time it's going to take to calculate the SSDE if you set it up properly. But hopefully if you're awake, you're asking me the question, what's a reasonable reference SSDE? Well, the simplest answer is the SSDE for the patient should be equal to the adult SSDE. What does that mean? That means that the dose to the child is equal to the dose to the adult. You say, well, Keith, a big deal. What, don't I want the dose to the child to be less? Well, yeah, ideally, but what would the dose to the patient have been if you didn't adjust the technique at all? It would be 2.5 times greater for that smallest pediatric abdomen. So you've grabbed the low-hanging fruit. Now, I made this assumption when I put the protocol on the Imagenologia website back eons ago in 2008. That was light years ago. Okay? This is conservative. But I think it's relatively appropriate for the adult institution that does children occasionally. Because what's part of the equation here that we haven't addressed? The interpretation. I hope you believe in the concept as I do that you are best at what you do routinely and most. If I do something once or twice a year, or once a month, or once a week, I'm not going to have the same acumen and efficiency as if I do it frequently. My point is that while adult radiologists can read pediatric scans, they will not be as proficient at it as pediatric radiologists, and that's all they do. I would advocate it for that reason that we should give the adult radiologist a little bit better image quality than what's required by the pediatric radiologist. And that's exactly what this is doing. All right. Now, how do we reduce? What guidelines do we use to reduce the SSDE? Well, we can take the original high voltage, which is probably 120 kV, and we can reduce the mass. It's, just simply the ratio of the reference SSDE over the calculated SSDE, and multiply that times the mass. Problem with that is that if I just reduce the mass, what's going to happen to the noise in my image? It's going to go up. My image quality is going to be less. Should I reduce the kV for pediatrics? Sure, I should. Well, here's a scheme where I can reduce the high voltage and keep the same dose to the patient. I set the appropriate reduced mass so that my dose is the same. That came from that table that's back in the Imagenologia website. I note the displayed CTDI vol at 120 on the scanner. I reduce the kV to the desired value. Maybe that's 100 kV, maybe it's 80, depending on the size of the patient. And I turn up the mass until the CTDI vol at the reduced kV is equal to the original CTDI vol 120. My dose is the same. My kV is reduced. My image quality is going to be improved because there's going to be more contrast in the image at the same dose. That's one scheme. Another scheme is I can reduce the high voltage and I can also reduce the dose. It's a little more involved. I start out the same. I dial up the reduced MAS technique, as I did before. I note the displayed CTDI vol 120. I measure the increased contrast at my targeted lower kV versus 120. How do I do that? Well, almost all of you have got an ACR accreditation Fathom available to you, and it's got some low contrast objects in it which you can use to calculate the contrast to noise ratio. And you can make some measurements at 120 kV, and you can make some measurements at the lower kV find out how much the contrast is increased, or you can use the CTDI phantom with iodine pins if you have those. You want to make sure you're using the clinical field of view that the site's going to use in the clinical bow tie filter. All right? So we know how much our contrast has increased. We can calculate how much our noise is going to increase because we reduced the KV, because we know that relationship. So let's just say that my contrast goes up 40%. My noise went up 60%. Because I dropped my kV from 120 kV to 100 kV and kept the mass the same. Well, I want the contrast to noise ratio to be the same, so I want to reduce my noise, and I do that by increasing my mass until my noise is 40%. So my contrast went up 40%, my noise went up 40%, my contrast to noise ratio is unchanged relative to what it was originally. So I've essentially maintained my image quality, and I've reduced my dose. So you can use either scheme. So some additional considerations. Well, how much can the high voltage be lowered? Well, it depends on the task. It depends on the patient size. And of course, as I lower the kV, I'm going to change the contrast, I'm going to change the noise, I'm going to change the artifacts, and I'm going to change the scanning speed. So let's look at that a little bit. My contrast is going to go up as my kV comes down. I'm going to have higher noise levels if I change nothing else. And so typically I'm going to want to increase my MAS in addition to dropping my kV. If I drop my kV, my radiation output and MR per MAS goes down, and as a result of that, I may run into problems with radiation output of the scanner because it's limited. I may need to reduce the pitch. I may need to reduce the rotation time so I have time to produce more radiation. So B and C are going to increase the scan time, and I'm going to have essentially more motion on sharps. Yes, sir?
Seems to be increased.
Oh, I'm sorry. Thank you. Okay. Beam hardening. Lower KV. I'm going to tend to have more streak artifacts. It's going to be more problematic if I have high contrast objects, dense materials in the patient anatomy. Okay? So there are trade-offs in lowering the KV. Another important thing to keep in mind is I can't keep the contrast to noise ratio the same for children. I can, but it won't be acceptable. I need more contrast to noise ratio for infants and small children, partly because there's less adipose tissue between the organs and the tissue interfaces. I typically use thinner slice thicknesses with kids, which is going to increase the noise in the image. And radiologists will tolerate higher noise levels in adult images than they will in pediatric images, in part because the anatomy in the pediatric image is a lot smaller. So last Sam's question. When reducing high voltages of the CT scanner in an effort to improve image quality and reduce the radiation dose to pediatric patients, one can ignore the effect on contrast, noise, sharpness, artifacts, scanning speed. Timer's underway. Okay. 2/3 of you got the right answer. Sharpness is not important to us. We'll have more artifacts to deal with lower KV. And depending on the size of the patient, we may or may not have some scanning speed issues to deal with and some motion on sharpness in the patient. All right. I want to say just a couple quick words about automatic exposure control. There was a wonderful talk at the Dose Summit about a lot of things that you have to worry about with respect to using AEC for pediatrics. Things like you've got to make sure the patient's centered, et cetera, in the gantry. I want to point out a couple other things that are very important. This is an article that was published by John Boone and others in 2003. The title is Dose Reduction in Pediatric CT, a Rational Approach. And basically what this article did was it assumed that we wanted to keep the contrast to noise ratio constant as a function of patient size in managing pediatric techniques. That was the rational approach. Now, it doesn't work for the reasons that I've already stated, but that wasn't well understood in 2003. And look what we could do if it worked. We could reduce the MAS by a factor of 35 on the smallest pediatric patients relative to the largest adult patients if indeed we could keep the contrast to noise ratio the same. So we've talked about this a little bit. Infants compared to adults, the subject contrast is less, their body parts are smaller. One other point that I want to make, that if you haven't been around kids, all parts of our bodies don't grow at the same rate. You may find that odd, but our heads only increase in size by a factor of 1.4 as we go from an infant to an adult, and if our abdomens increase about double in thickness. Now, this is a 2-year-old child, and happens to be my grandson, and you see the size of his fist compared to my hand. The old adage is, what's the size of our fist? Our heart. Think about the poor pediatric cardiologist that has to work on something that's the size of this little guy's fist. Pediatric imaging is more of a challenge than adult imaging just because of size. So we require more image quality. Now, what about the different manufacturers? Well, manufacturer A in this case is Siemens. They have CareDose 4, and basically they specify an age, a specific age of a patient, and if the patient is less than this size, you use a reference mass of 80, and if they're greater than this size, you use a reference mass of 200. And there's nothing in between. And you say, how does this work? Well, it does work because of a lot of things going on behind the scenes, all the way from newborns to adults. And this gives us a clue about something that's very important. The contrast to noise ratio increases as a factor of 3 times as I go from my newborn to my adult. Remember a minute ago I said I needed more contrast to noise ratio for my infant compared to my adult, but I didn't tell you how much more I needed. Siemens figured it out quite a while ago and realized that it was about a factor of 3. That means that my mass is going to increase by about a factor of 3 for my adults compared to my children to give me acceptable images. Now, the contrast to noise ratios that I'm talking about here, I actually measured with these anthropomorphic phantoms. This is simulates a newborn, and this simulates an adult. Manufacturer B, that's GE, uses a noise index, which is proportional to the standard deviation of the noise in the image, and you set a noise index and you set a minimum and a maximum MA and a scan time. Well, GE made the same mistake that John Boone and others made back in 2003. It assumed that the same noise index could be used regardless of the patient size. If I use the same noise index, essentially my contrast to noise ratio will roughly be the same. Not exactly, because my contrast is changing between my newborn and my adult, but my noise in the denominator obviously would be the same if my noise index is the same, because that's what it's trying to do. Okay? So obviously this fails. Now, another thing that I warn you, if you try to set up automatic exposure control on a system like this, one of the things that the scanner doesn't do that it should do is that if it hits the maximum MA or the minimum MA, it doesn't give you a warning. It just simply hits that maximum and provides the scan. Well, what does that mean? That means that you never achieved the noise index that you selected. And that creates a lot of confusion on the operator's part because they don't realize that they hit the ceiling on the tube current And as a result of that, they think that something's wrong with the noise index that they selected, and it just compounds the problems. So when you have a standard noise index type system, the contrast to noise ratio, we want it to decrease by a factor of 3 as we go from a newborn to adult. We want the MAS to increase by a factor of 3, and that, of course, means my noise index is going to increase by a factor of 3. And I've got to be careful about selecting the minimum and maximum MA. Okay, so I had 2 other topics that I wanted to talk about. We're almost out of time, so I'll stop here so we have time for a few questions.
Yeah, I think it's important to take a few minutes if we have some questions.
I have 2 questions. When we talk about the CTDI vol, the DLP, and then for the SSDE, most of the machines did that, and you work with tube people, and people aren't tubes. When you have a vastly varying body size across the scan, and you get a single CTDI vol and you get a single DLP, when we know the mass has been varying not only while you go around the patient, while you go up and down the patient, then you take your SSDE factor and correct for some portion of that patient. How off can you be when the patient's not a tube? That's my first question.
Okay. So obviously there's going to be error associated with that because, as you've said, there's one average CTDI vol value that's presented by the scanner at the end of the case, and that supposedly is the average, represents the average tube current that was used during the entire scan. Mm-hmm. So someone's asked me the question specifically, where do I make my measurement if my patient thickness is varying? Well, I think we can agree that if I were doing a chest, I wouldn't want to measure the lateral thickness of the patient at the shoulders because that's not going to represent the majority of the scan. Likewise, I may not want to make the measurement at the thinnest portion of the patient. But I will say this. If you make the measurement at the thinnest point of the patient, what will you do? Will you overestimate or will you underestimate the dose if you make a measurement at the thinnest point of the patient? You'll overestimate the dose. If you make your estimate of size at the thickest point of the patient, you'll underestimate the dose. I would advocate that you probably want to pick a thicker point and a thinner point and do some kind of weighting to come up with one thickness that you're going to use to reduce the amount of error because we only have one CTDI vol.
Well, the ACR program that's being run in the DR database is doing that automatically. Do you know how it's doing it?
They're receiving they're receiving projection scans from the facilities that are sending them DR data. And exactly the point at which they're making that measurement, I don't know. Do you?
I think it's just halfway.
Halfway? Okay.
Okay, so it's halfway.
So there's potentially an error there.
Yes.
Okay. The second question I have is more imaging based, especially when we're talking about pediatric cases. What's your feeling towards how image quality is affected by how fat the pediatric patient is? Not, if we have a 2-year-old who's fat and a 2-year-old who's fit, and we're making these adjustments, how much is the image quality affected by that fat to clinically interesting tissue? Because they can't be the same. I just wonder how much they might vary when you take your approach.
Okay. So that was discussed at the Dose Summit over the last day and a half, and basically if the fat is contained within the abdomen, it makes it, the radiologists are saying it makes it easier to distinguish the individual organs if there's dispersed fat within the abdomen. If all the fat is external to the internal organs, that fat's going to reduce contrast in the image, and it is going to essentially make the imaging task even more difficult. So I would advocate that with children, it's not really the absence of fat that's a problem. With children, it's the problem comes from the physical size of the patient anatomy. It's a lot smaller. And as a result of that, you're going to need better image quality to make the same interpretation.
That if I see a 2-year-old who's obese, an external fat on his body, I shouldn't make a correction for that factor, or I should take it into consideration?
Oh, when you what? To calculate the SSDE? Oh, clearly you should.
To make these corrections you were talking about.
Well, essentially what you're really talking about is reducing your KV. And, you know, on a 2 or 3 year old, you're probably going to go down to 80 kV anyway. And once you get to 80 kV, you really can't do anything more with your KV to improve image quality. You may be able to do something with the kernel or the algorithm that you elect to do your image processing and to reformat the image. But you're not going to be able to do it with scan parameters at that point.
Along that line, has anyone anyone looked at the possibility of using weight as the predictor?
It's a great question. Can you use weight as a predictor? And the answer is weight is better than age, but not much better. If you're going to use weight, you also need height. Okay? Because I can have a tall, thin patient that's a lot heavier than a short patient that has the same amount of girth. Okay? And the other thing that's a problem with kids, they're constantly changing size. I know the patient's birth date on the day that I scanned them. But if there is a weight that's entered in the patient's medical record, I may or may not know the date on which that weight was taken. Maybe that was taken a year ago and entered a year ago, and at that point the patient's obviously bigger. Thank you very much.
All right, let's thank our speaker again.